Welcome back to pharmacology. We're continuing looking at toxicology. We've just looked at toxicokinetics. Remember that was what the body does to the toxin, and we looked at various absorption, distribution, elimination effects, the various sites by which you might eliminate toxins. Luckily for some of them, it's the same site where you're exposed. It's at the skin, or you inhale that toxin and inhale it straight back out. But where we needed to get an indication of at what dose, it might then exceed the body's systems of removing those toxins quickly, where we then start to compartmentalize those toxins. Now, one of the other major toxicokinetic parameters was that metabolism, where we used paracetamol as our example of what level of detail we want you to go to in your own compiled diagrams, showing the many mechanisms of toxicity, where you may need to look at oxidative stress, peroxidation, any changes to ion channels in those membranes of cells and organelles once they've been damaged by a toxin, or perhaps if it's the particular CYP that are involved in that metabolism, or other body metabolizing enzymes. So now we start to look at toxicodynamics, the mechanism by which that toxin harms the body and what those protein targets are. As that toxin interacts with the target, it makes it dysfunctional in some way, and then that leads to all of the toxicity patterns. So we said the higher the dose, the more the dysfunction of target molecules in general. But it did depend upon exposure, and it did depend upon timing. Right, so if it's DNA, that was, our example of radiation that might damage DNA, you would need to go into some detail about how that radiation damages DNA, leading to its destruction. Some toxins, as you're exposed to them, they might bind to your body proteins, but that body protein becomes a new antigen and you show an allergic response, not so much to the toxin, but to your body's ability to change its distribution pattern. Now, other toxins are just straight out necrotic, where you will talk about that process. Usually these targets are parts of just normal cell maintenance. But if you've got a protein or an enzyme, a structure in the cell that's part of cell signaling and cell regulation, where apoptosis controls those cell numbers, sometimes toxins increase that apoptosis or damage those cell signaling mechanisms. And with necrosis, it's very hard to repair, but with apoptosis, we may be able to stop the apoptotic processes going on in that tissue. With DNA, we're able to repair it. So sometimes it's not that the toxin is actually directly toxic, it's that we get exposed to the toxin so much that eventually there is disrepair. The actual toxic process is where our repair mechanisms are overwhelmed beyond homeostasis, and that is when the xenobiotic or other agent of radiation might become toxic at those levels. And so it's more about measuring the efficiency of the repair process. That's what the dose response curve is actually measuring. And so there it might be a TD50 that's a more appropriate dose estimate of toxicity. Inflammation will be one of those important mechanisms of toxicity, and if it is, and that's the one you choose to go into in some detail, well then that's one of the reasons we've asked you to do this toxicology assignment to that level of detail with mechanisms of toxicity, because that's going to help you later. We're going to look at body defenses, and we're going to look at drugs that target body defenses. So the more you could review now, the better for later. So yeah, not all drugs and toxins, though, will cause this this inflammatory response or other immune response changes. But if inflammation is one of the mechanisms of toxicity of your toxins, then you might want to specifically mention if there's measurable, notable research on changes in bradykinin or histamine or prostaglandins, or perhaps it's tumor necrosis factor alpha, a major mediator of necrosis in cells. It might be interleukin 1 or interleukin 2 in immune responses, or interferons, also in looking at immune responses and inflammatory responses to tissues. And then when looking at cell regulatory signals, colony stimulating factor is one of those important mediators. And so the more of those you can review now, the more it will pay off later when you study the drugs. So I'll just mention in some detail one of those mediators that we've mentioned before. As our example, we looked at prostaglandins. We looked at how their production is via this enzyme cyclooxygenase. We didn't mention that there are actually two targets. So we have COX-1 and COX-2 enzymes. And some of the drugs are selective and some are non-selective. We use that term selective when we were talking about the target. Now, these drugs are not specific either. There are a whole range of other proteins unrelated to COX. They may not even be proteins, but other physiological responses in the body that these drugs target and damage. These are the adverse drug reactions. Aspirin and paracetamol do have adverse drug reactions because they do target other systems in the body other than COX-1 or COX-2. Now, as a way to cut down adverse drug reactions, pharmaceutical companies might try and make them more selective, and this is a non-steroidal anti-inflammatory that was more selective for COX-2. This cut down a whole range of adverse drug reactions, but in post-marketing surveillance, a whole range more of cardiovascular problems were then seen, and some really worrying ones where there was deaths reported. So because of this particular drug, celecoxib, is under a bit of a black box by the Therapeutic Goods Administration and other approving authorities around the world. But have a look at the name, the generic name, where we've tried to build into the name some information about what this drug targets, and you can see in its name that it targets the COX enzyme. The brand name is Celebrex. But to now have a look at some toxicodynamic and toxicokinetic data applied to one particular toxin. To give you an example of the sorts of things we're looking for in your research, we've chosen alcohol as our example. It's a xenobiotic. We do not make alcohol. It is foreign to our bodies. If any alcohol is made in our body, it's actually made by our normal flora bacteria. So we're normally exposed to small levels of alcohol, and the key word there is small. Remember, toxicity is all about the size of the dose. It's when you ingest large amounts of this toxin, where we said it has a kilojoule or a calorie value. More on that alcohol dehydrogenase shortly. But how it also then has a deleterious effect on our normal flora bacteria. It causes them to release part of their cell structure from their wall, an endotoxin. And it's this endotoxin that travels then from the gastrointestinal tract via the portal circulation to the liver and does a lot of the damage there. So when you hear a person telling you that the bacteria leave the gut and go through the portal circulation to the liver and cause problems when you eat toxins, then you would die. You'd get such a serious acute hepatitis, you'd be dead within days. No, that doesn't happen. It's that we damage and disrupt the bacteria in our gut, and their cellular components go to the liver. But yes, they most certainly do a lot of inflammatory damage there. And so chronic alcohol users produce long-term changes in their liver. But those binge drinkers also get this massive release of endotoxin, causing inflammation, and if they continue to binge, then it's that chronic acute binging that damages the liver. But we'll see that there's many other mechanisms by which alcohol is toxic as well. So the sites where it's absorbed, it's interesting because some of it's absorbed through the stomach. Remember that thick prostaglandin-induced layer of mucus that stops absorption, mostly of hydrochloric acid through the stomach, but also a lot of other chemicals. But water and other small molecules, alcohol, can be absorbed. But largely the small, but also the large intestine will absorb alcohol if you continue ingesting it in very large amounts. Of course, the significance of our large intestine absorbing alcohol is it's mostly our normal flora in the large bowel that naturally ferments and makes small amounts of alcohol for us, and so we were absorbing, once again, even smaller amounts of that alcohol, and we have in our liver evolved many mechanisms then for dealing with small doses of that alcohol. But it distributes to other body tissues, water-rich tissues, but having that hydrocarbon small component being ethanol, it will also cross the blood-brain barrier and will distribute to adipose tissue. So we have seen then that will affect the elimination of that alcohol. However, if it doesn't distribute to your adipose tissue, there's more available because you don't have a lot of fat, you're a thin, small-framed person, then most of that alcohol will be staying in the systemic circulation. Therefore, there may be higher levels to distribute to the brain. So explaining how the same ingested dose of alcohol might have different effects on people depending upon their body shape and size. So it's eliminated as is. It can be excreted without metabolism, but it's largely metabolized to increase that excretion. So the first key enzyme, that was that alcohol dehydrogenase, not just found in the liver. That's the key thing. The liver is the major site, but the kidney is also another site where you have that enzyme. As you are excreting raw, unprocessed alcohol through the kidneys, you are also processing some of it and biotransforming it to get a faster elimination rate. It's a toxin. We want to get it out of the body. So that alcohol dehydrogenase is converting ethanol to ethanal. The chemical name, ethanal, commonly known as acetaldehyde, and ethanal has been studied as the weak mutagen. So remember, we said we want you to get down to the nitty-gritty of the levels of toxicity and the mechanisms by which toxins cause that damage. So we don't want with your particular toxin to just say it's a carcinogen. If you can explore that in some detail and see, is it the primary mutagen, is it a promoter substance or a co-carcinogen, and here we have that acetaldehyde or ethanal, a weak mutagen. It's more than your timing and the chronicity, how chronically exposed to alcohol you get, as to how much cumulative mutagenic damage your DNA in your hepatocytes will suffer. So the whole aim of that metabolism, biotransformation on that alcohol, is to convert it to acetic acid actually, so that it can be excreted faster. So even in the kidney, the acetic acid is the substance that is more easily transported out into the urine, into the filtrate. And we said that alcohol has this hormetic dose-response curve, where in incredibly small doses, quite frankly, it may have a protective effect against stroke and coronary vascular diseases, but it very rapidly, a rapid J shape, rapidly becomes toxic in increasing doses. So this concept of saturable metabolism that we mentioned, here we have all of these normal natural mechanisms for removing this toxin alcohol in small doses. We have alcohol dehydrogenase. we have the ability to excrete it unchanged using transporters in the kidney. But if all of those proteins are saturated and all of the metabolizing enzymes, some of the ones we haven't even mentioned yet, but it's CYP, if they're all saturated with alcohol molecules, then if that person continues to ingest the toxin, it might be that very next drink, though small, that might put the person over into a toxicity profile. Or for a social drug like alcohol, a social poison like alcohol, it might be that one extra drink that then takes you over the legal limit for driving. So you'd have to mention those aspects of its toxicokinetics. Now, some other interesting things with alcohol and the way that it's eliminated. It's eliminated directly on the breath. It's exhaled. That's the reason behind roadside testing. But as we said, also in the urine. It induces that CYP fraction, a cytochrome P450 in hepatocytes, which is usually that smooth endoplasmic reticulum. You get more of those proteins in the membranes of that smooth endoplasmic reticulum when you drink alcohol regularly. In small amounts, that's just going to speed up the elimination and then to give you a protective effect. But very quickly, as you ingest more and more, it will saturate those metabolic processes. When it's acutely toxic, alcohol can directly kill, but oftentimes that's an indirect killing or indirect cause of injury to people through motor accidents, or in workplaces, people who shouldn't have been operating machinery or working at heights and so on. So you talk about those social aspects of it if you were researching a similar related substance. Now, alcohol is a chronic toxicity pattern. We mentioned that through alcohol dehydrogenase it has some kilojoule value or caloric value, but small. But because of that small caloric value, it puts chronic alcoholics off eating, and they become vitamin deficient, particularly this one that we mentioned there, thiamine. In addition, as a chronic pattern of exposure, alcohol induces reactive oxygen intermediates, and this is what leads to the lipid peroxidation. Note that as one of the key mechanisms of toxicity, that if you find that for your particular toxin, that's the thing we want you to report on. Most people just list a whole range of final end stage responses. They'll say cirrhosis, or they'll say esophageal cancer, or they will say fatty liver, and not give any mechanism in between of what has occurred in terms of exposure, timing, levels, and at the cellular level, what metabolizing enzymes, what molecular targets, or what metabolizing processes have led to that damage for at least one of those symptoms or end stage responses of toxicity. Go into it in some detail. We're going to just very briefly look at overdosing on toxins. We will once again use alcohol as a good example where there is poisoning and particular lifespan stages where alcohol is a worse toxin for people at that particular stage in their lifespan. But we will also talk generally now about poisoning in general. So when it comes to this important point, poisoning in children, before we look at elderly, lactating women and a few other examples, prevention is, of course, a far better measure than any kind of cure for an overdose. I'm going to actually use paracetamol as my example here because we've said because young children explore more with their mouth. That's how they investigate, feel, that if they have round disc-shaped objects, they will try and swallow them, whether they taste sweet or not. They treat them like they're lollies, and so this has happened quite a lot with paracetamol. Paracetamol overdose in children, where because they are toddlers, you can't ask them what they took. doing that risk assessment, very, very difficult with children. With some toxins, if you know what it is, you can do a gastrointestinal decontamination. The old-fashioned gastrointestinal decontamination procedure is an emesis to induce vomiting. But there are other mechanisms. However, with children, oftentimes that procedure is more risky than the toxin, because if that child inhaled any vomitus, that could set off sequelae that could produce more morbidity or greater risk of death. So that might be the only point of difference with some overdoses in children. A lot of times, if you know the toxin, then it's proceed as for adults. This is certainly true if the child is over 6 years and it was a self-induced poisoning. You do have some sort of an idea as to what they have taken. Many adults deliberately, of course they often deliberately take too much alcohol, but they often deliberately take too much paracetamol, this time armed with the information that paracetamol is toxic to the liver. They set out to deliberately self-harm, and it's believed that perhaps 15% of all cases of paracetamol self-induced poisoning in adults is for self-harm purposes. So once again, this is this idea of a population parameter giving a measure of these more bizarre adverse drug events as self-induced poisoning. With alcohol, we mentioned we'll keep using that as our example to give you some ideas for your assignment. It is important to note that the fetus is at greater risk of the toxic effects of alcohol than the pregnant woman or any other person, and this fetal alcohol syndrome, an actual syndrome that if you had used a similar toxin and there was a similar fetal effect, that you would mention that. Now to look at pregnancy and lactation and some of the toxicokinetic parameters that are important here. Speaking pharmacokinetically, that's when we were talking about drugs. We said that drugs are absorbed differently in pregnancy because of different absorption effects, distribution effects, and elimination effects. There's changes to capillary networks and vasculature, and changes in the kidney and so on that affect the absorption, distribution, and elimination of drugs. So when it comes to toxins, sometimes, because of all of those changes in pregnancy, it might be worthwhile considering if the woman was close to the end of her term to induce labour, rather than deal with the toxic effects of that substance on the fetus, just induce labour. Most drugs will cross the placental barrier, so will most toxins. Most drugs cross into breast milk, so will some toxins. And so when you're looking at exposure levels, you may want to just really look at that and think a bit laterally, and not just look at levels that might be in drinking water from those food packaging or other sites of exposure. You may want to then look at how much of it might then accumulate in breast milk, because sometimes the toxic effects for the newborn are quite dangerous, more dangerous for the baby than for the mother, but that the breast milk is one of those tissues where the toxin does compartmentalize. Now similarly, some toxins are a greater risk for a fetus than they are for the mother. There will be a toxic response in the mother, but because of the greater risk to the fetus, all of the risk management is done for the fetus if there was an overdose. We've given some example agents here where the risk for the fetus is greater. We've got carbon monoxide, substances that induce methemoglobin to persist in the body. This is a whole range of drugs. Lead is more toxic for a fetus than it is for the mother, and salicylates fall into this category. You may be researching some of those toxins, so that will give you some clues as to how to ensure that you have covered the criterion for trying to address some of the theoretical concepts from the toxicology material. And then last of all, alcohol, which we've been using as our example. There are some serious risks to the neonate if a breastfeeding mother is consuming high levels of alcohol, because being still quite water soluble, it will concentrate into breast milk. Now with the elderly, it's the same thing as with kids. Getting that risk characterisation is sometimes hard because you can't find out what actual toxin they have taken. So that's all of those challenges that you had with young children being unable to tell you. The elderly so quickly go from a confused state to a delirious or a comatose state that they can't tell you what substance they have been exposed to. After exposure to a toxin, there's often higher complication rates in the elderly when there has been a poisoning situation or when they have deliberately self-harmed. All of the pharmacokinetic profiles that we talked about that change in the elderly, they are the same toxicokinetic profiles. They will have delayed gastrointestinal absorption, decreased protein binding, reduced hepatic metabolism. They'll have less of that smooth endoplasmic reticulum and less of those metabolizing proteins, and their ability to induce them will be either slower or not at all. And there will be a reduced glomerular filtration rate. And all of those pharmacokinetic changes means that if it was a toxin, those toxicokinetic parameters change and make the toxin even more toxic. We'll see that when we use some examples of lithium and digoxin later when we study them working, in the case of lithium, in the nervous system for bipolar disorder, and digoxin on the failing heart. So in the elderly, they very rapidly could go into an acute renal failure, though it's been a chronic exposure to that drug, that lithium, over time. So after that acute toxicity from a toxin, there'll be a delayed recovery because of all of these changes to the toxicokinetic parameters going on in the body, and that's going to lead to longer hospitalization times. That in itself leads to various sequelae. The complications of immobility are deep vein thromboses or perhaps pulmonary embolism and so on. So quite serious risks for the elderly. And now last of all, to use our example substance, alcohol, and effects in the elderly. Well, once again, small, low doses, actually more associated with those elderly people getting out and having a social network, laughing and feeling connected in their community. And it's probably those flow-on effects rather than the alcohol itself that actually might be protecting that person against the stroke or the coronary artery disease. There may be some direct effects of the alcohol, but by reverse, if the person is taking very, very large doses of alcohol, in general that's associated with more isolation and depression among the elderly. Now last of all, we consider in poisoning situations some classic syndromes. This is relevant to natural healers because you may see some people who are in a classic poisoning syndrome, and you may be the person then to alert emergency medical services for this person. So the common syndromes to look out for: anticholinergic syndrome from a range of substances. So it's particularly an antimuscarinic syndrome where the person's mouth will be incredibly dry, and other classic symptoms. So by reverse, a cholinergic syndrome. This will produce excessive salivation and other classic symptoms because that this poison, whatever it might be, is overstimulating at acetylcholine receptors, particularly the muscarinic receptors. So here we've got sarin, a toxin. It was released in a Tokyo subway and killed quite a few people. So all of those terrorist issues that are now impacting on society, if you've chosen one of those agents, you would mention those sociological impacts. But in terms of its mechanism of toxicity, you would talk about it as being this acetylcholinesterase inhibitor. It inhibits the enzyme that breaks down the acetylcholine. The acetylcholine stays at the synapse for longer and so keeps producing its muscarinic effects. So that cholinergic syndrome could also come from a range of other agents. We'll talk about some of these in more detail shortly, such as nicotine or mushrooms. They might produce an agonist effect for acetylcholine at certain receptors. Of course, with nicotine, it'll be the nicotinic receptor. The one that we want you to be aware of is the serotonin syndrome that occurs with a whole range of agents, psychoactive drugs, hallucinogens. We'll talk, as I said, about mushrooms and a few other sources of those hallucinogens shortly, but it will be their pharmaceutical antidepressants or their herbal antidepressants, such as St. John's wort. So make sure you do go and look at that appendix at the back of your textbook that gives those herbs and talks about a few important drug-herb interactions, and note St. John's wort there in the table. So this is the serotonin syndrome. We want you to think of it as a triad. It's a triad of CNS effects, autonomic nervous system effects, and neuromuscular effects, where there is dysfunction in all of those areas. So in the CNS, the person will become quite agitated. As far as autonomic dysfunction goes, the person is going to sweat a lot. There will be a diaphoresis. A CNS as well as a neuromuscular dysfunction will be ocular clonus, but in addition there might be hyperreflexia of tendons and those tendon reflexes. There might be clonus of other muscle groups, or there might be complete muscle rigidity in certain parts of the body. So all signs of this triad of overdosing effects on a whole variety of nerves and at the neuromuscular junction. Okay, so the sorts of things that can lead to this triad of symptoms, this serotonin syndrome: LSD, ecstasy, and amphetamines, which are your Schedule 9 substances, drugs prone to abuse. But we did indicate it's your antidepressants, pharmaceuticals. I'm going to mention some mechanisms, because if you are looking at a substance where it says it produces a serotonin syndrome, you're going to have to mention serotonin, and you're going to have to mention its reuptake mechanism. And so this acronym here, SSRI, is an antidepressant that targets selectively the reuptake of serotonin, and it actually inhibits it so as to lead to higher levels of serotonin available at the synapses in the CNS. But if the person overdoses on the antidepressants, then they likewise overdose on the serotonin, and hence the triad of symptoms will then start. Some of the drugs aren't so selective. They are serotonin, noradrenaline reuptake inhibitors. So when you talk about the adverse effects from an agent that might produce a serotonin syndrome, and there is all sorts of cardiovascular problems as well, it'll be because of the increased levels of noradrenaline. You're telling us the mechanism of toxicity. And you'll also see that you are preparing yourself and getting ready in advance for another body system and the drugs that act there. When we look at that, you'll have a bit of a background. Now, one of the other mechanisms of action of these drugs of abuse, mushrooms, other herbal medications, it might be this enzyme, monoamine oxidase. And so the toxic agent is an MAOI. It's a monoamine oxidase inhibitor. You've told us the protein target, and you've told us the mechanism of action of the toxin. It inhibits that protein target. So this will be seen with some dietary supplements where clients might be taking too much of it. Other herbal preparations where they think, oh, a little must be good, more must be better, and then they put themselves into a serotonin syndrome. So it could be ginseng, it could be that St. John's wort from Hypericum porphyratum. It doesn't matter what the source, you'll get the same triad of symptoms in overdose, but don't just list the symptoms, try and explain the symptoms at the mechanistic level. Talk about what is being affected. Is it non-selective? Is it affecting both serotonin and noradrenaline and their reuptake? Is it inhibiting it? Is it affecting this monoamine oxidase enzyme? Is it inhibiting it? Is it affecting the reuptake of not only serotonin, which is 5-hydroxytryptamine, and noradrenaline? Is it also affecting dopamine as well, where you then might see a different range of symptoms with that particular dietary supplement, herbal preparation, mushroom, etc. Okay, so get very, very specific about which neurotransmitters might be put out of balance with that particular overdose situation. So in summary, we looked at some important toxicokinetic parameters that, as with drugs, with toxins, you can look at dose-response curves to predict toxic effects. But it was a wider picture than that. It also depended on exposure first, and that determined the dose. There was also timing issues and other effects. But we saw also that there is a variety of processes going on where the body acts on that toxin that also affect dose levels, response levels. It was absorption, distribution and elimination of that toxin, where you might have to eliminate from more than one compartment. One of those compartments might be somewhere where the toxin sequesters or builds up. The aim is to eventually get it to then reverse and move out of that stored compartment back into the main compartment, the systemic circulation, where it then might actually meet its target and be toxic, but where the body and its other processes might have a chance then at detoxifying and removing back to safe levels where the margin of safety is being met. We saw with overdose situations that one of the mechanisms by which we might treat that is enhanced gut elimination, emesis and so on, but it could also include charcoal perfusion. So if you have a toxin, once again a supplement, a herb, a plant, and you're studying it and overdose is a problem, then please tell us how it's managed. You've got to mention some management aspects if you can, or even, as we said, the antidote. So the idea of that enhanced elimination is it will then move out of the compartments to where it has sequestered and then eventually be removed from the body. So biotransformation was also very important, and as always the CYP is very important in those processes, but to be aware that there are other metabolizing systems in the kidney, in the gut and so on. Now sometimes they can explain the toxicity of the substance, paracetamol being a good example, is it which is actually transformed to the toxic metabolite that damages the liver. Generally that metabolism is so as to eliminate that toxin faster. So the same parameters that we measured for drugs, we measure for toxins. The toxicokinetic parameters: clearance, volume of distribution and half-life. We commonly used alcohol as our example to show these principles of toxicology, where we saw that it does depend upon exposure but also timing. There's binging on alcohol, there's chronic effects, there's also this long-term low-dose beneficial effect. So you had to look at the dose-response curve and how abstinence from alcohol for whole of life may not even be beneficial, may lead in the elderly to isolation and depression, just like excess alcohol could lead to isolation and depression. So there was a whole range of lifespan issues. You couldn't mention all of them in your assignment so long as you addressed that issue. If there was some other areas from the toxicology theory concepts that you hadn't touched on, then you might want to meet that criterion by talking more about the lifespan issues. So yes, we talked about alcohol, but also with paracetamol, that in overdose children were particularly susceptible. Adults do self-harm with paracetamol, that it isn't the paracetamol that is actually dangerous, it's its metabolite, NaBQI and imine, that reduces glutathione, that you would go into some detail about that mechanism of toxicity, and then the available antidote, which for paracetamol was acetylcysteine.